Good morning. Is everybody here? Somebody needs to answer. Hello.
Doctor.
Good morning, Doctor.
Yes.
Who's the head of the class? Razin, is it?
Yes, me and Sakina.
Is everybody here?
Ada lagi 2 orang.
Dua orang lagi.
Right now it is
Just want to check, presenters patutnya 4 kan?
yes.
Did all of you send me the slides or only 2 of you? Because I only had 2 slides, only 2 people sent me slides, so who are the presenters? Nama?
Me, Nurul Syafiqah, Doctor.
Huh?
Nurul Syafiqah.
Syafiqah, you didn't, right?
I already sent to Sister Farah email.
To Sister Farah, but you
Yes.
didn't send to me.
Oh,
Tak rasa pelik ke tak ada respon? You send to Sister Farah. Farah mana?
Sister Farah.
The pediatric administration.
Kamu hantar kat Farah buat apa? During last seminar, the one before that already I gave you guys my email, right?
Yes.
Lepas tu tak ada respon, tak ada benda, tak terfikir.
Sorry, Doctor.
It's not sorry to me, it's sorry to yourself. I don't know what's happening with your presentation. Hazrin hantar, Sharifah hantar, Sharifah Inshira. Siapa lagi seorang? Presenter.
Me, Doctor. Afiq, not mine.
Afiq?
Yes.
Afiq, hantar ke tak? Ada hantar ke tak hantar?
No.
Tak hantar, okay fine. I mean you guys are adults lah, you should behave like adults lah. If you want to send for it to be checked out to see whether you're on the right track, then you send. But if you send and you don't get a response, then obviously something is off, isn't it? Semua orang dah ada? Kalau dah ada, start je. 33, patutnya 35 kan, including saya kan?
Betul.
2 orang lagi siapa?
I'm still searching for this.
Okay, tak apa. Kalau tak ada, start je dulu. Razin,
Yes, saya.
nampak tak siapa yang lambat tu? 2 orang tu.
Saya sedang cari.
Put your names in the chat box, nanti saya nak tengok. Okay,
baik.
boleh start. Siapa start dulu?
Assalamualaikum and good morning. So today I will present about acute glomerulonephritis. Okay, so here is the table of content. There are 5 parts. I will divide into 5 parts. The first one will be introduction about the disease and epidemiology. The second one will be pathophysiology and causes in relation to the sign and symptom. And the third one will be clinical features that focus on the symptom extent and also complication. And the fourth will be diagnosis that will include detailed history and also investigation. And the last one would be principle of management that can be divided into 2, which is supportive and also specific management. So we will move to the first part, which is the introduction that will talk about the disease and also epidemiology. Okay, so by the definition itself, acute glomerulonephritis. Nephritis means that inflammation. So glomerulonephritis means that inflammation of the glomeruli due to the proliferation of the glomerular tissue. And then glomerulus is composed of endothelial cell, mesangial cell, and also visceral epithelial cell. So we can see at the picture, here is the endothelial cell, and here is the mesangial cell, and also here is the visceral layer of the epithelial cell. So there is proliferation of these 3 cells. So the glomerulus become hypercellular and also it becomes enlarged. So what triggers the inflammation and the proliferation of this glomerular tissue. So it actually antigen antibody complex in the glomerular basement membrane, and it induces complement activation. So that's for the definition. And then for the interaction, acute means abrupt or sudden onset. So acute glomerulonephritis is when there is an abrupt onset of one or more features of an acute nephritic syndrome, such as edema, facial puffiness, microscopic hematuria, which is tea-colored or smoky urine, oliguria, decreased urine output, hypertension, azotemia, which is elevation of blood urea nitrogen, and also serum creatinine level. So the epidemiology of this disease is that in the worldwide, it is caused by IgA nephropathy, and usually in our country, the most common one is post-streptococcal glomerulonephritis. So it is common in children, and it develops after 1 to 2 weeks of streptococcal infection with a male to female ratio of 2 to 1. Okay, next, we'll move to the next part that will talk about pathophysiology and causes of acute glomerulonephritis in relation to the symptoms and also signs. Okay, but before we move to the pathophysiology, we need to know first what is the etiology of the acute glomerulonephritis. Okay, so it can be divided into two. The first one will be infectious and also non-infectious. But usually for infectious, it will be post-infectious. So in Malaysia, the most common one is post-streptococcal glomerulonephritis, which is Streptococcus species group A beta hemolytic. Okay, it could also be virus such as Epstein-Barr virus and also parasite. So if we cannot find the infection, so the common cause after the infection is IgA nephropathy, which is very common in developing country now because infection there is less. So other non-infectious could be because of crescentic glomerulonephritis, membranoproliferative glomerulonephritis, and also autoimmune disease such as SLE, Henoch-Schönlein purpura, and also Goodpatcher syndrome. Okay, so for the pathophysiology of acute glomerulonephritis means that I will give example for the post-streptococcal infection. So after about 1 to 2 weeks of the infection of the streptococcal species, the antigen antibody complex will deposit on the glomeruli. And then we know that antigen antibody complex will activate the complement pathway, which cause inflammation and also proliferation of the cell within the glomeruli. So what is the proliferation within the glomeruli? I have said before is that proliferation of the endothelial cell, mesangial cell, and also epithelial cell. So mesangial cell is actually inflammatory cell like a macrophage. So when there is inflammation, it causes capillary wall damage that leads to hematuria. That's why glomerulonephritis present with hematuria. And then because of inflammation, there is reduced in glomerular filtration rate, GFR. Okay, so when there is reduced GFR, patient will present with reduced urine output, oliguria, and also azotemia, which is increased blood urea nitrogen and also creatinine level. So reduce in GFR also cause fluid retention, which is salt and water retention. And then there is reduced in renal blood flow, leads to renal release. So salt and water retention, and also there is renal release. These two factors, it will lead to hypertension. Okay, next, we'll move to the clinical features that will discuss about sign and symptom and also complication. For the specific symptoms, there are a few. The first one will be edema at the periorbital, scrotal. The next one will be facial puffiness, smoky or tea-colored urine, hematuria, and reduced urine output, which is oliguria. So as we can see the picture on the slide, the urine is tea or cola-colored urine, and there is a periorbital edema. Okay. For the non-specific symptom are anorexia and lethargy, abdominal pain. So there are a few cardinal features of acute glomerulonephritis, which are hematuria, oliguria, azotemia, and hypertension. But actually, proteinuria and edema are also common, but not as severe as nephrotic syndrome. So for the general sign of acute glomerulonephritis, the general signs are hypertension, papular edema, and skin lesions such as impetigo and also cellulitis. These two skin lesion, impetigo and also cellulitis, are caused by group A beta hemolytic streptococcus. Okay, we move to the complication of acute glomerulonephritis. So what happened? Okay, the first, the complication of acute glomerulonephritis can affect the central nervous system that can cause hypertensive encephalopathy. So when there is increase in proliferation of the cell in the glomerulus, it will reduce in the GFR and lead to reduce in urine output, and also there will be fluid retention. So there will be fluid overload. Okay, because of that fluid overload, patient will have headache and restless. And for late hypertensive encephalopathy, they will have visual disturbance, vomiting, and also seizure. So for the respiratory system, acute glomerulonephritis will reduce the renal blood flow. So it will increase the renin release that lead to hypertension. Okay, so the consequence of hypertension will be left ventricular hypertrophy, and it will lead to left heart failure, and this will cause pulmonary edema. Okay, and then acute glomerulonephritis also can progress to nephrotic syndrome, rapidly progressive glomerulonephritis, and also finally irreversible renal failure. Other complication is severe uremia due to reduce in GFR. So there will be fluid and electrolyte retention. So it increase the plasma potassium level that will cause arrhythmia, and also increase in this potassium plasma level will cause metabolic acidosis and leads to small breathing, which is deep breathing compared to the normal one, as we can see at the graph. Okay. Next, we will talk about diagnosis, which focus on the detailed history and also investigation. Yes, doctor?
Ravita, you need to speak a little slower, please.
Okay, doctor. Okay, next, we will talk about diagnosis, which will focus on the detailed history and also investigation. So by asking a detailed history, it can help us to have a few differential diagnoses. So for example, what is the differential diagnosis of edema in the pediatric? So we can ask about past medical history to identify any risk infection or systemic disease. For example, if the patient had sore throat or skin lesion, which is a honey crusted lesion, that may be because of streptococcus infection, or the patient have autoimmune disease such as SLE, HSP, and also Goodpasture syndrome. So the next one would be we can ask about the birth history, because low birth weight also increase the risk to get the acute glomerulonephritis. So for the immunization, we need to ask if there is allergic reaction due to the injection and cause edema. So for the dietary history, it is important in order to ask, because some child will manifest this symptom, which is loss of appetite. And then for the family history, we need to know if the family members have autoimmune disease or renal failure, because this will also increase the risk factor. And then, so the differential diagnosis of edema in pediatric could be because of many systems, such as for the affect the kidney, it could be kidney problems such as nephrotic, and then it could be cardiac disease, it could be hepatic failure, it could be gastrointestinal, because we can lose protein through the gastrointestinal tract, so and others. Okay. So we move to the investigation. Investigation is important in order to confirm or to eliminate some of the list of the diagnosis. The first one would be urinalysis and also culture. The result could be hematuria and RBC cast, which is pathognomonic for acute glomerulonephritis. So the picture there is the example of RBC cast. Actually, the urinalysis and culture also we can see the other cellular cast and also proteinuria, but proteinuria is usually traced up to 2+ only. But if more than 2+, we need to consider the nephrotic syndrome, and also pyuria may also present. The next investigation would be bacteriological and serological evidence of antecedent strep infection. It can be done by throat swab or skin swab, because antibody to streptomycin O titer and antigen B is raised, because it is our body's response to a strep infection with group A streptococcus. The third one will be blood investigation. We can order for full blood count, renal profile, complement levels, and also immunological markers. So for the full blood count, we can check for the infection, renal profile to assess renal function, complement levels to check for the C3 and C4, and immunological markers such as anti-nuclear and anti-double-stranded DNA antibody for SLE, and anti-neutrophil cytoplasmic antibody for Goodpatcher syndrome. So the graph below shows the natural history of the acute post-streptococcal glomerulonephritis. Okay, so weight and urea start to decline by the 5 days to 10 days. Hypertension and gross hematuria can be resolved by the 2 to 3 weeks. And then C3 level is low at onset of the symptom, and it will become in the normal limit by the 6th week, while C4 level is usually within the normal limits. So for the microscopic hematuria, it will persist for months to a year. So because of that, the patient needs to follow up for at least 1 year and monitor the blood pressure at every visit and do urinalysis and renal function to evaluate the recovery. But actually, this disease, which is acute glomerulonephritis, it has an excellent prognosis with 95% recover completely. The last one would be imaging. So we can look for the chest X-ray to look for cavitation. We can look for nodules or mass in the lung. And then actually renal biopsy is not done as a routine for nephrotic syndrome because if the case is straightforward and responsive to the treatment, but there is some indication for the renal biopsy to do. For example, the first one will be steroid resistant, a typical presentation or severe acute renal failure, prior history of renal disease or family history of nephritis. Yes, doctor.
Why you put steroid resistant there? You're talking about glomerulonephritis, right? AGN, right?
Yes, doctor.
Why do you treat AGN with steroids?
Actually, I follow the PACE protocol. So
I know you follow the PACE protocol, but everything has a context, isn't it? Right?
if
Context. If you're talking about, because if you're talking about acute glomerulonephritis, most of the time you're talking about post-strep GN, isn't it? Right?
yes,
Do you treat glomerulonephritis with steroids? No. Do you treat glomerulonephritis with steroids?
Doctor, even though for this, for example, the streptococcal will cause a skin lesion, right, doctor? So
Yeah.
maybe
Will cause skin lesions? No, they do not cause skin lesions. This is a very simple question. Do you treat acute glomerulonephritis, particularly post-streptococcal glomerulonephritis with steroids? No, right? So,
no, doctor.
So you should, why is there a why is there a word steroid resistant there? Then you're gonna give the impression that GN is treated with steroids. This is a general indication for renal biopsy. We are talking about steroid resistant nephrotic syndrome here. You understand that? This is the indication of renal biopsy is steroid resistant nephrotic syndrome. It's not, you're not talking about AGN here. You understand?
I think I get it.
Yeah, you should clarify that this is actually talking about steroid resistant nephrotic syndrome, not nephritic syndrome. You are now presenting about nephritic syndrome, isn't it?
Yes, doctor.
Yeah, so you're going to confuse your friends, right? Because this is a general indication for renal biopsy, I think.
Oh, for both nephrotic and doctor.
Yeah, and if you're
Okay,
going to put that steroid resistant, you need to add steroid resistant nephrotic syndrome. And atypical presentation in nephrotic syndrome, severe acute renal failure, fine. That is fine. But that steroid resistant, that's going to confuse your friends. You understand? Everybody?
Yes, doctor.
Your Shafiqah is presenting AGN, but AGN is not treated with steroids, okay? Okay, continue.
Okay, as doctor said, I will repeat again. So indication of renal biopsy, the first one would be steroid resistant. It's actually manifestation for the nephrotic syndrome, not AGN, okay? Okay, because we do not treat AGN with this steroid. Okay, indication of renal biopsy can also suggest the non-post-infectious acute glomerulonephritis. What is non-post-infectious, such as SLE, SSP, and also good posture syndrome. And also, if there is delay resolution, for example, oliguria for more than 2 weeks, azotemia and also gross hematuria more than 3 weeks, and also persistent hematuria more than 6 months. So we will move to the last part of the presentation, which is the principle of management. It can be divided into two, supportive and specific management. So for the supportive management, the continuous monitoring is important because we need to take the urine output, fluid intake, daily weight, and also blood pressure. Why is that important? For example, weight is important because the child may have edema, so it can affect the brain and it may lead to convulsion or seizure. And then it is also important to take care about the input and output chart, because we need to because the child may have pulmonary edema and also high blood pressure, which is hypertension. Okay. And then penicillin V is also given for the patient for the post-infectious glomerulonephritis. And then for the acute glomerulonephritis, fluid restriction is very important because we need to control the edema and also the blood pressure of the patient. And then the next one would be diuretic if the children have the pulmonary edema symptom and sign, and then hypertension. For the diet, we need to give salt-free, and then we need to look out for the hypertension and complication of the post-streptococcal acute glomerulonephritis, such as hypertensive encephalopathy, pulmonary edema, and also acute renal failure. So the specific management for the acute glomerulonephritis would be the first one would be hypertension. We can give a few antihypertensive drugs. The first one would be nifedipine. It actually, we give oral nifedipine, and then if it does not work, we give furosemide, and then captopril, and then metoprolol. The specific guideline you can refer to the protocol. So for the pulmonary edema, the management is that sit up and give oxygen or intravenous diuretic such as furosemide, and then fluid restriction, and we can consider dialysis if there is no response to the diuretic. And then for the acute kidney injury, we can do the management such as peritoneal dialysis and also hemodialysis. I think that's all from me. Is there any question?
Shafiqah, can you go back to your first slide? Next. Excuse me, stop. Now, most commonly, when you are talking about acute glomerulonephritis in the pediatric population, the common one that you're talking about will be the post-struct GN. Okay, so this one, post-struct GN. Now, the infection get is usually the glomerulonephritis is immune mediated. So the infection is actually happens before the presentation of glomerulonephritis. So maybe they'll have a sore throat, or they have cellulitis, or they have impetigo roughly about 1 to 2 weeks before the onset of the urinary symptoms. Okay, so it's not together. It means the child gets the streptococcal infection first, and then like roughly about 2 weeks later, then they start getting hematuria or edema. Next. 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 Okay, now, excuse me. Back. Back. Shafika, back. Shafika, back. Shafika, back. Back up. Ah, here, stop. If I don't tell you to, if I don't tell you
Doctor, I
to,
cannot hear you clearly. Back.
then don't flip so fast if I don't tell you to. Excuse me. Shafika, stop.
Sorry, doctor, my connection is unstable.
Next. Okay, stop here, please. Now, for all intents and purposes, post-rep GN is hematuria, hypertension, and edema. Okay, hematuria, oliguria, exothymia, not so much. Hypertension and oliguria. There is a little bit of they may be proteinuria, but for all intents and purposes, as third-year medical students, when people ask you for the features of acute glomerulonephritis, just mention gross hematuria, hypertension, oliguria. Some edema, don't need to mention proteinuria, okay? Because proteinuria, yes, it can be present in AGN, but it's not a main feature. And if it's persistent, then it's maybe not AGN in the end. So all you guys should remember is the first four, okay? Next. Now, sorry, the signs here, the skin lesions, like I said just now, right? The infection doesn't occur at the same time as the GN, as the AGN. So all these cellulitis signs should have either resolved or is resolving. You wouldn't see this active cellulitis in a person who is having AGN, right? Because it's an immune-mediated process, should be post-infectious, right? But you might see impetigo scars. Do you guys know what impetigo is? It's kind of those round circular scab lesions on the kids' legs when they get an infection, kind of look like mosquito bites. They got infected. Those are impetigo. Okay, so whenever you do a short case, you must look up for those signs. Next. 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 Back, please. Family history of autoimmune diseases. Just now, Shafika said it increases the risk. Not quite, it's also for you to take a history and also to see whether maybe later on, whether if the proteinuria is persistent, whether it's not a straightforward post-rep GN, it's more of a secondary glomerulonephritis or secondary to one of those autoimmune diseases. Next. Next. Now, investigations, what you do an FBC, right? You do a renal function. Complement level C3, C4. C3 will be low on diagnosis, C4 will be normal. After 6 weeks, the C3 should normalize, right? The immunological markers, that's to screen for connective tissue diseases. Usually what happens is that the child doesn't need to be admitted for the duration. Usually the disease will resolve by about 2 to 3 weeks, okay? The child can go home if the child's normotensive without any antihypertensive medication, okay? There is no gross hematuria, right? Microscopic hematuria will persist to up to 2 years, okay? As long as it's microscopic and not gross, then don't need to worry about it, right? But the gross hematuria should resolve by 2 weeks. If the gross hematuria doesn't resolve by 2 weeks to 3 weeks, then the child needs to be investigated further. Okay, you guys know what the difference between gross hematuria and microscopic hematuria? No?
Yes.
Mustafa, what's gross hematuria? What's microscopic hematuria? Mustafa.
Yes, doctor.
Yeah, what's gross hematuria and what's microscopic hematuria?
Gross hematuria that we can see it by our eyes. Gross hematuria only by in the investigation that we can see it. We can see it by our eyes, isn't it?
So gross hematuria, basically, when you look at the P looks red, right? You can see it grossly lah.
Yes.
So microscopic hematuria is only identifiable when you do a urine FEME, right? Urine full examination, microscopic examination, right? Then only you can see. But grossly, if you look with your eyes in microscopic hematuria, the P will look basically like normal P lah. Okay. Now, microscopic hematuria can persist up to 2 years after the episode of post-rut GN. If it persists more than 2 years, then the child needs to be investigated further, right? If the child has gross hematuria, then supposedly the post-rut GN has resolved, then like few months down the line, develops gross hematuria again, then the child needs to be investigated, okay? If the child has microscopic hematuria and also proteinuria that persists after 6 weeks, the child also needs to be investigated. You understand, right? The only thing that's allowable in the urine FEME after the episode of post-rut GN has resolved is microscopic hematuria up to 2 years. If there is any proteinuria, investigate. If there's a return to the gross hematuria, investigate. Okay? Okay. Continue. Next. Chest X-ray, not so much to look for cavitation, vaginal spermatosis. I think in the acute phase, it is more to look for signs of pulmonary edema. Don't you think, Shafiqah? True or not?
Yes, doctor, actually. But
You don't copy and paste. I mean,
Because
everything is contextual, I know, but everything is contextual because you are talking about investigations in the acute phase, isn't it? True or not? In relation, but what?
I'm not too confident to change it.
I mean, excuse me, this is like taking a screenshot of a tweet without looking at the full thread, isn't it?
Yes, sir.
True or not? I mean, whatever that is the reason you guys need to think critically, not everything copy and paste. It is correct for the information is correct, but it's only correct from the source that you took it from. If you're going to take it out from the source, then you need to look at it and see whether it fits or not. You cannot just blindly copy and paste. Okay? Not to say you cannot copy and paste, but at least look through it and see whether it fits your narrative or not. Okay, next. Next. Now, basically, if it's post-rut GN, it's basically supportive, right? So one of the things, investigations that you need to do is also to show evidence, say that's post-rut GN, you need to show evidence that there was a streptococcal infection. That's why you don't need to do an ASOT titer or throat swab, right? If your ASOT titer is low or negative, and then you cannot label it as post-rut GN, okay? Then you need to see what other causes it possibly may be lah, right? So if it's post-rut GN, then you give penicillin, yes, that's to eliminate the streptococcal infection. Basically, it's supportive, right? So it's a fluid overload, obviously fluid restriction, diuretics, right? If there's hypertension, then obviously antihypertensive. Which antihypertensive you use depends on how edematous the child is, right? If the child's edematous, then maybe a diuretic would work better than just a purely nifedipine antihypertensive. So we put it here. Okay, next. Next. Okay, done. Okay.
Thank you, doctor.
Okay, next presenter siapa?
Me, doktor.
Mi tu siapa?
Sharifah Nur Ishira.
Yeah, you have to I mean, you guys have been on Zoom for a while already. You know, if you see me, nobody's gonna know who's talking, right?
Okay, good morning everyone. I am Sharifah Nur Ishira binti Said Muhammad with matric number 1912716. I will present to you about the nephrotic syndrome. So for the outline for our presentation today is definition, epidemiology, etiology, pathogenesis, history taking, physical finding, investigation, complication, differential diagnosis, management, and prognosis. So first, for the definition of the nephrotic syndrome itself, nephrotic syndrome is a clinical syndrome of massive proteinuria defined by edema, proteinuria, hypoalbuminemia, hypercholesterolemia. So proteinuria is indicated by urinary excretion more than 40 milligram for an hour. And for hypoalbuminemia is serum albumin level is lower than 25 gram per liter. And then the hyperlipidemia is indicated by cholesterol level more than 250 milligram per deciliter. So next, for the epidemiology of the nephrotic syndrome. Nephrotic syndrome is actually can be happen at any age, but it is more prevalent in children. In children, it occur for the school age children and adolescents, and it is more common in young males rather than in young females. So for the site distribution is equal in older patient. The prevalence worldwide is approximately 16 cases per 100,000 children worldwide. So next, for the etiology of the nephrotic syndrome, it has two causes, two etiology for the nephrotic syndrome. First is the primary, or we call it as idiopathic. It is the commonest type of the nephrotic syndrome in children. Approximately 90% of children have idiopathic nephrotic syndrome. It is absent of an identified systemic disease, meaning it doesn't present like in a secondary etiology for the nephrotic syndrome. The ratio for the male to female is 2:1. It is most commonly appears for the children at age of 2 to 6 years old. So minimal change nephrotic syndrome (MCNS), which is one of the primary, which is one of the idiopathic nephrotic syndrome, is the most common one that occur in the patient. Also, we also have mesangial proliferation and focus segmental glomerulosclerosis (FSGS). So next, for the secondary etiology is it is a presence of an identified systemic disease. It is suspected in patient more than 8 years old, or patient who does have hypertension, hematuria, renal dysfunction, extra-renal symptom, or depressed serum complement level. So the secondary is causes by the infection, HIV, HBV, or HCV, and also caused by drugs, NSAID, and immunologic, SLE, and also malignant disease. So next, for the pathogenesis of the nephrotic syndrome, it is the underlying abnormality in nephrotic syndrome is an increased permeability of the glomerular capillary wall, leading to proteinuria and hypoalbuminemia. It has two, which is the role of the podocyte itself and also the immune system. So for the role of the podocyte, podocyte is actually the highly differentiated epithelial cell located on the outside of the glomerular capillary loop. Okay, the food process integrated with each other is connected with by slight diaphragm, and it is terminated at the basement membrane. The function of the podocyte is as a structural support of the capillary loop. It is a major component of the glomerular filtration barrier to the proteins. So next, if there is any gene mutation occur in podocyte, it will cause increased glomerular permeability and will lead to the increased protein leakiness to the glomerular wall and across the glomerular wall into the urinary space, and causing the proteinuria. So as we can see, the proteinuria here is heavy proteinuria, and then the proteinuria will lead to the decrease in serum albumin, and hypoalbuminemia occur. And then for the hyperlipidemia, when the liver is in a compensatory synthesis, where because the low serum albumin, so the lipoprotein will increase the catabolism and the hyperlipidemia occur. So for the edema is due to the decreased colloid osmotic pressure and lead to the fluid accumulation in interstitial tissue, and edema occur. And also from the decreased colloid osmotic pressure, we could lead to the decrease in plasma volume and decrease in GFR, glomerular filtration rate, and increase in aldosterogen secretion, and then the sodium and water retention, and will lead to the edema. So next, for the role of the immune system, for the MCNS may occur after the viral infection or allergen challenges. MCNS has also been found to occur for the children with this condition, which is Hodgkin lymphoma and T-cell lymphoma. Also, the immune system where the immunosuppression occur with drugs, corticosteroid and cyclosporine. So for the history that we would like to find for the nephrotic syndrome, first is the edema itself. We could ask for the site of the swelling. It is obviously in the periorbital, lower extremities, quarter for the male patient, and or labia for the female patient. It will become generalized and can be massive. For the onset is whether it is intermittent or insidious. The characteristic of the edema is usually soft, heating, and non-erythematous. It could progress rapidly or slowly. Also, we could ask for the specific time of the swelling. It could be worsened. Usually, it could be more noticeable in the face in the morning, and more dominant in lower extremities later in the evening. And then for the associated symptom, we could see that the patient may appear lethargy and be less active, and also abdominal pain, loss of appetite, decreased urine output, or diarrhea. So next, for the history that we could ask is the past medical history, whether we would like to ask the history of joint stiffness, photosensitivity rash to exclude the SLE. Also, the history of heart disease to exclude cardiac edema, history of renal disease, or history of this same illness, whether he or the patient have a nephrotic syndrome before. And then for the drug history, the nephrotic drugs, whether it have take the nephrotic drugs. And then for the family history, we would like to ask whether the family members have the renal disease of the autoimmune disease. And for the nutrition intake, we could ask for the protein intake or the allergic to any food. And then the immunization, what is important for the pediatric patient is we expect for it to be up to age. For the physical examination, for the skin, for the general examination first, we could see that the patient appear lethargic and irritable. The patient could be will be paler. Also the facial swelling, especially at the periorbital area, like in the picture. Then for the skin, we could look for the facial swelling and look for the malar rash or the features of the SLE. For the eyes, the periorbital edema. The limb, like the picture below, bilateral repeating edema in lower extremities. And for the respiratory, if there are any complication of the pleural effusion, we could see the ipsilateral reduced chest expansion, decreased tactile parameters, dullness to percussion, and inaudible breath sound. So next, for the cardiovascular, we could search for the Gallop rhythm. So if there is no, so we could, if it is yes, it could to rule out the heart failure. For the abdominal, in this patient, we could we search for the inspection, which is distended on palpation, distance and tenderness, and on percussion is fluid thrill and shifting dullness. We check for the ascites, and the auscultation is normal bowel sound. So next, the investigation. This is the like the complementary investigation on the to diagnose with the nephrotic syndrome. First is the urine test. Urinalysis, we use the urine dipstick. It's indicated by the high urine albumin concentration. Also the quantitative urinary protein excretion. We have two examination, whether it's first morning urine protein to creatinine ratio. We could see the proteinuria more than 200 milligram per millimole, and 24-hour urine protein measurement. Proteinuria is more than 40 milligram per meter square per hour. And then for the blood test, we could see the liver function test. We particularly for the serum albumin, we expect the serum albumin to be low, which is less than 25 gram per liter. And then the lipid profile, we expect it to be high, the hyperlipidemia, which with raised total cholesterol, triglyceride, and lower density lipoprotein, the LDL. And then this is the investigation to rule in or to rule out the elevated hemoglobin level and hematocrit indicate the hemo concentration and intravascular volume depletion, and publicum is often to be increased. So renal profile, we check for the urea, electrolyte, and creatinine level, and also we want to assess for the acute kidney injury. For the serum electrolyte, it is a hyponatremia due to decreased free water excretion, and also for the complement study to rule out the SLE and the post-infectious glomerular nephritis, which is low level in C3. And then for the anti-nuclear factor to exclude the SLE, and also the isotiters to exclude the post-septococcal glomerular nephritis, and other tests to check for the secondary etiology for the nephrotic syndrome, such as the HIV, hepatitis B virus or hepatitis C virus. For the imaging, we do the chest X-ray for the children with respiratory symptoms, such as the pleural effusion. So next, for the complication, the hypovolemia, the children may develop the hypovolemia. Hypovolemia occurs when the hypoalbuminemia, albumin decrease, so it will be decrease the plasma oncotic pressure and resulting in a loss of plasma water into the interstitium. So we could see that there is low in circulating blood volume. So it only be observed when the patient's serum albumin is less than 1.5 gram per deciliter. So the clinical features is the abdominal pain, cold peripheries, poor pulse volume, hypotension. And then for the primary peritonitis, it is due to the urinary loss of immunoglobulins and complement. Clinical features is the fever and the abdominal pain and tenderness, in whether in the newly diagnosed nephrotic syndrome or the relapsed nephrotic syndromes. So next, for the thrombosis, it is made due to the hypocoagulable state resulting from the vasculostasis, intravascular volume depletion. So the factor contribute is the immobility, because the patient couldn't move a lot, and also the infection of the presence of the central venous catheter. So differential diagnosis for the children with the nephrotic syndrome. Usually, patient with the nephrotic syndrome is initially present with generalized edema. So other causes of childhood generalized edema need to be considered as a differential diagnosis, such as for the acute kidney injury, APGN, the heart failure, also the liver cirrhosis, and HIV or HSP, or or other than stated above. So next for the management, this is being taken from the PACE protocol. So for the also usually we give the patient with initial episode of the nephrotic syndrome. Patient first come and we give the prednisolone 60 milligram per day for 4 weeks. So if there is response here means that the attainment of remission within the initial 4 weeks therapy. We will taper the prednisolone for 25% monthly over 4 months. But if there is no response or the steroid resistant or failure to achieve response to an initial 4 weeks treatment with prednisolone, we will go to the renal biopsy. So and then if there is a relapse here means urine albumin excretion is more than 40 milligram per hour for 3 consecutive or urine dipstick of more or 2 more and more 2 plus for the 3 consecutive days for the relapse. So we will give to the prednisolone for 60 milligram per day till remission. Remission means the urine dipstick trace or nil for 3 consecutive days within 28 days. So and then we will alternate. We will give the 40 milligram for the alternate day for 4 weeks and then stop. If there is a frequent relapse, we will reinduce like the first, like the 2-1, like the prednisolone 60 milligram, and then we alternate it and then we give it 40 milligram for the alternate day, and then we taper and keep low dose alternate day prednisolone for 0.1 to 0.5 milligram per dose for 6 months. If the patient is relapsed while on prednisolone, we will treat it as 4-3 if steroid is not toxic, and we will consider cyclophosphamide if the steroid is toxic. For the oral cyclophosphamide, we will give to the 2 to 3 milligram per kilogram for a day for 8 to 12 weeks. And then if there is a relapse from using the cyclophosphamide, we will return to the 2 and the 3 if the steroid is not toxic. But if the steroid is toxic, we will refer to the pediatric nephrologist to consider therapy with the cyclosporine of limamizole. So this is the definition for the outcome for the corticosteroid, whether it is response with which is mean attainment of the remission within the initial 4 weeks, and then remission is urine dipstick trace or nil for 3 consecutive days within 28 days, and relapse urine albumin excretion more than 40 milligram, or the urine dipsticks more than or 2 for 3 consecutive days, and the frequent relapse 2 or more relapse within the 6 months of initial therapy, or 4 or more relapse in any 12 months periods of the therapy. For the steroid dependent, it means the 2 or more consecutive relapses occur during the steroid taper or within 14 days of cessation of steroids. And then for the steroid resistant, it's a failure to achieve response to an initial 4 weeks treatment with prednisolone at 60 milligram, where we give to the renal biopsy. And then for the prognosis, steroid responsive means the repeated relapse with decrease in frequency as the children grows older. So each response remain rapidly to steroid. We could say that those who have no relapses during the first 6 months after diagnosis and likely to follow the infrequently relapsing course, which I have already mentioned before. The steroid responsive patient is unlikely to develop chronic kidney disease. about 90% of children with MCNS will achieve the remission after the initial course of steroid treatment. For the steroid resistance, it is mostly often caused by FSGS. Generally have much poorer prognosis. It could develop progressive renal insufficiency and lead to end-stage renal disease, and it may require dialysis or kidney transplantation. So the recurrent nephrotic syndrome developed in 30 to 50% of transplant recipients with FSGS. So this is my reference, and that's all. Is there any question? No. If no, I will go to Dr. Chan.
Sharifah, or not? Any questions for Sharifah? Sharifah, what's ASOT?
And anti-streptolysin O title.
What's it for?
It is for the streptococcus, for just now the post-streptococcus glomerulonephritis, for check for the antibodies for the streptococcus A bacteria.
What's FSGS?
FSGS, focus segmental glomerulosclerosis.
Okay, can you go back to the first slide, please? Okay, so nephrotic syndrome, 4 things: edema, proteinuria, hypoalbuminemia, hypercholesterolemia. In children, you don't need to remember the hypercholesterolemia so much, but please remember the cutoff points for proteinuria, and hypoalbuminemia, okay? So proteinuria, either it's 40 milligram per meter square per hour, or early morning urine PCI, protein creatinine index 200 milligrams per millimole. Pay attention to the units, because different labs will use different units. So if the labs use different units, you must make sure that you convert the units back into this unit so that you know the levels, okay? Don't take the number at face value. Sharifah, how do you collect 24-hour urine protein? If the child is 1 year old, if the child is 3 years old, can you?
I'm not very sure about.
So if your child is 3 years old, which type of urine test would you do? PCI or or 24-hour urine protein?
Years old, PCI.
How do you collect PCI? Is it a morning sample, afternoon sample, evening sample, night sample?
Morning.
Do you take the sample any time of the day? Does it matter?
Yes, we should use take in the early morning.
So morning, right? Okay. The younger the child is, if the child is not toilet trained, it's a bit difficult to take 24-hour urine protein. Okay, you do not put in a catheter just to collect 24-hour urine protein. So if the child is 3 years old, early morning PCI should be sufficient lah. Okay. If the child is older, then you can do a 24-hour urine collection. Next. Okay, nephrotic syndrome versus nephritic syndrome. Nephrotic syndrome, the age group tend to be a younger age group. The nephritic syndrome tend to be an older age group. Next. Okay, in kids, it's most usually minimal change nephrotic syndrome. So that's why in children, if the child has nephrotic syndrome, they don't do renal biopsy, unlike in adults, right? In adults, if adults have nephrotic syndrome, it's most likely secondary to something, so the renal biopsy is indicated in adults, but in children, it's not indicated unless you suspect that secondary cause, or unless it's atypical, or unless it's steroid resistant. Next. 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 Sharifa, I said look for pictures, right? It's the same two pictures that you put in your slide in the first. I mean, things like physical examination, if you're doing a presentation, it's easier to remember pictures than to remember words. Generally, if you're presenting, less words. So usually kids with nephrotic syndrome tend to be generally edematous, right? So you see periorbital edema, you see pedal edema, there will be ascites, another signs of fluid overload. Just as a general rule, if you guys are presenting something with signs and symptoms, just look for pictures and put the pictures on. It's very much easier for you guys to remember rather than this. Next. Even this also, you don't actually need to. I mean, as a presentation, if you just wrote the investigations without writing so many words, that's actually enough, because you're going to be presenting anyway. You're supposed to be reading your textbook, not reading the lecture notes, by the way, for everybody. LFT, so LFT, 24-hour urine protein or PCI. What's your FBC? Next. Okay, FBC, make sure you look at the hematocrits, because the kids will be hemoconcentrated. If you're hemoconcentrated, very increased risk of getting thrombosis. Renal function, obviously. Next. 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 Okay, now, nephrotic syndrome, the treatment is with steroids, okay? So, if at initial presentation, your steroids will be 60 milligram per meter square per day for 4 weeks, okay? Irrespective of whether they go into remission before that 4 weeks. Okay, so it's 4 weeks and then cut down to 40 milligram per meter square every alternate day for 4 weeks, and then they'll taper down. This is different from a relapse. If the child has nephrotic syndrome, okay, already diagnosed, had it before, already treated adequately, okay, then a few months down the line, get a relapse. When you get the relapse, the high dose of prednisolone, that 60 milligram per meter square per day, is only until remission, not a full 4 weeks. You understand or not? Right? Remission meaning urine albumin is negative or trace for 3 consecutive days. Now, how do you know whether the child goes into relapse or is in remission or not? The parents will need to have home monitoring. So before every child goes home, they need to be taught how to monitor the urine albumin and how to keep a notebook on their early morning urine results, okay? Because if they go into relapse, if they are not, you want to catch them before they become edematous so that they don't need to get admitted. Usually if the child goes into relapse, but does not have complications, the child doesn't need to get admitted to the ward. Do you understand or not? So before discharge, after diagnosis, every child will be taught how to keep track of their urine albumin and how to keep a log of their urine albumin in a small notebook. Okay, so that's very important. Parent education and patient education is very important, because they are supposed to check their urine every single day and their morning urine every single day, and keep a log of it so that they can catch when they go into relapse. And if they go into relapse and they're given prednisolone as an outpatient, when they can track when they go into remission, and then they can cut down the prednisolone by themselves. You understand now? Okay, so the dosage, the high dose prednisolone during initial diagnosis and the high dose prednisolone after relapse, the duration is different, okay? So don't confuse them, can see, right? So if the child responds to steroids, so they're steroid sensitive, meaning they go in remission within 4 weeks of diagnosis, okay? Steroid resistant, meaning they take the high dose steroids, but after 4 weeks, they still don't go into remission. Frequent relapses are those who relapse 4 times out of 12 months or 2 times out of 6 months after initial diagnosis. All these definitions you guys must memorize. The next one. Next one. All this you must, yeah, you must memorize. Okay, what's a remission? What's a relapse? What's a frequent relapse? Your steroid dependent. Your spelling is wrong, Sharifah. D-E-P-E-N-D-E-P-E-D-E-P-E-N-D-E-N-T. That spelling is for a person who's dependent. Anyway. Steroid dependent, 2 or more consecutive relapses occurring during steroid taper. That means once the child's steroid dosage is reducing, they go into relapse. Or they stop the steroids within 14 days of stopping steroids, they get another relapse. Those are steroid dependent. Steroid resistant. Okay, fine. Now, go back to that slide, Sharifah. Now, cyclophosphamide is a steroid sparing medication, right? So basically, its use is to prolong the child being in remission so that the child doesn't become more steroid toxic. Okay, because steroids by itself, high dose, you can get, there are side effects, right? The kids can become Cushingoid, right? So that where you get the glaucoma, you get the cataracts, you get your Cushing's features, hypertension, you get your central pedal obesity. Okay, so kids who are steroid toxic may need to consider to go on cyclophosphamide later. That's, you guys as third years, just know that if you're steroid toxic, then you need some steroid sparing drugs. Next. Okay, by and large, most kids, they'll grow out of it. So by the time they reach teenage years, they stop having relapses. Most of them. Okay, but not all. Okay, next. Okay, done. No questions, next presenter.
Thank you.
Who's next?
Sorry, Doctor. Yeah, wait.
Doctor, can I ask a question regarding nephrotic syndrome? Hello?
Your question?
Yeah. I am Sakina, doctor. I want to ask, so there are a lot of like nephrotic syndrome patients that will come twice to the clinic to check their blood for monitoring their medication, if I'm not mistaken. Is it because do they need to monitor both the steroid or just cyclophosphamide?
What medication are they on? If the child is, then no, there's no need to take blood. If you're talking about cyclophosphamide, then yes. Or cyclosporine, then yes. Then they need to check for their
Oh, yes.
FPCs because they can get leukopenia, right? Then they also need to check their renal function. Okay, because these are also the kids who are steroid resistant, isn't it? And also cyclosporin and cyclophosphamide by itself also can sometimes increase your urea and sugar. So those are the complicated cases, right? The simple minimal change in nephrotic syndrome that usually encounter in the clinic shouldn't need any blood taking.
So that one is complex lah.
Yeah, they are probably on cyclophosphamide or cyclosporin, right?
Alright,
The ones that
alright.
you see in the ward are also usually the complicated ones, because the ones that don't relapse frequently or basically can be treated as outpatient, they don't get admitted to the ward, right? So only the ones that are complicated get admitted to the ward.
Understood. And one more question, doctor. I've read that the symptom should be like you will see face swelling first, and then it will progress into lower body. But then we met a patient. The patient said that the sweat. Sorry.
No, it's not face swelling first. Nobody said face swelling.
Oh, all right, okay. Because I've read it
Why?
in a book.
Face swelling first.
Huh? Sorry.
The thing is this. What is generally more noticeable? Pedal
Swelling,
edema or facial edema?
facial edema.
Yeah, what is generally more
Oh,
facial edema, isn't it? So usually
yeah.
most of the time what people notice is the facial edema first, rather than the pedal edema. But the pedal edema would have already been there, isn't it?
I
Gravity
see.
dependent, lots of edema is gravity dependent. It makes more sense for the child to get pedal edema, isn't it?
Yep. All right. Thank you, doctor.
Can I start?
Yeah.
Okay. Okay, so good morning. My name is Nahajri binti Ibrahim, and I will be presenting about the systemic lupus erythematosus. What's not working? Okay. Okay, so this is the outlines or the contents of my presentation. Definition, epidemiology, risk factors, pathogenesis, clinical manifestations, investigations, criteria of diagnosis, management, complications, and the last one is the prognosis. Okay, the definition. According to pediatric protocols, SLE is a chronic multi-system autoimmune condition with widespread inflammation of blood vessels and connective tissue characterized by autoantibodies against self-antigens, especially presence of antinuclear antibody. So the epidemiology. SLE primarily affects women ages 20 to 40 with ratio female to male 4.5 to 1 in reproductive group. And SLE mainly, the onset of SLE is around puberty, and it is rare in children younger than 5 years old. And majority of the cases, about 85% of cases, present in children with age above 8 years old. And even though there is a female predominance in this disease during adolescence or adulthood, but there is an equal gender distribution in children. Okay, so what is the risk factor for SLE? The first one is the genetic predisposition, in which familial association, HLA association, and genetic deficiencies. For familial association, like family members have increased risk of developing SLE, and for HLA association, the odds ratio for person who has HLA-DR2 or 3 is 2 to 3, and also genetic deficiencies. Genetic deficiencies like deficiencies of complement proteins of classical pathway. For example, to be specific, like C1q or C2 or C4, this will lead to the deficiency or lead to the defective clearance of immune complex that will lead to the pathogenesis of the SLE that I will explain later on. And then for the environmental factors, UV light exposure, infections, and drug. UV light exposure can cause apoptosis, and this will lead to the burden of the nuclear antigens. Later on, I will explain also in pathogenesis. Also infections like to be precise, Epstein-Barr virus is associated with SLE, and drugs. Some drugs can cause SLE-like disorder, like hydrazalazine, procainamide, and D-penicillamine. Okay, that's what I remember. And then the third one is the sex hormone. Sex hormone, like estrogen. Estrogen is believed to cause B cells autoreactivity. Okay, that's all for risk factor. Now, pathogenesis. Environmental factors like just like I said before, the UV light, the drugs, and also the infections can cause apoptosis of the cells. And the defective clearance of the apoptotic bodies will lead to the increased burden of the nuclear antigen. And at the same time, with the underlying abnormalities of the B and the T cells or T lymphocytes, will lead to the defective in what we call it, defective in self-tolerance, so that this increased burden of the nuclear antigen will stimulate the self-reactive B and T cells. And this will lead to the production of the antibodies, and the autoantibodies and the antigen will form the autoantibodies antigen complex or immune complexes, and the endocytosis of these complexes, and also the toll-like receptor engagement by the nuclear antigen will stimulate both of the B and the T cells. And also the toll-like receptor stimulation of the B cells and dendritic cells are stimulated, right? And then the B cells will produce more autoantibodies, and the dendritic cells, when stimulated, it will produce interferon type 1 and also other cytokines. And this interferon actually stimulate both B and the T cells again, and this keep on cycle and leads to the persistence of the autoantibodies in the body and also immune complexes in the body. And the deposition of the immune complex in tissues and also in microvasculature will lead to inflammation of the joint, inflammation of many organ systems. Okay, and then for the clinical manifestation, SLE actually involve many systems, right? So many systems can, so the patient will present with many symptoms, including many organs, like just like you can see in the picture: skin, heart, blood, muscle and joints, kidney, lungs. And then this clinical manifestation is fulminant disease or indolent in manner, and it fluctuates with flares, progression, and remission. But the common non-specific symptoms are significant fatigue, low-grade fever, and weight loss. Okay, for the SLE, you can see from the skin, the patient may have butterfly rashes and red patches, and then you can have the mouth and nose ulcers, and then the joint pain or arthritis, and the blood, patient may have anemia, high blood pressure, and heart, endocarditis, atherosclerosis, inflammation of the fibrocytes, and lungs, pleuritis, pneumonitis, pulmonary emboli, pulmonary hemorrhage, and kidney, blood in the urine. And also the patient may present with neuropsychiatric manifestation like headache, migraine, mood disorder, cognitive impairment, and seizures. Also, the patient can have hair loss, or we call it alopecia, just like in the picture I put there. Okay, for the investigations actually is to, investigation in SLE actually is to establish the diagnosis and also to determine the prognosis, and the last one is to monitor the progress of the therapy. So I have listed several laboratory investigation for SLE. The first one is the anti-nuclear antibody. Anti-nuclear antibody, it is not a diagnostic tool for SLE because it is not specific for SLE, even though because high titer of ANA actually indicates other autoimmune disease, including the SLE. But due to its high sensitivity, but not specific, okay, due to the high sensitivity, like 97% of the SLE patients have high titer of ANA, so that we can use ANA test for screening for SLE. And then, so how to clarify the SLE is actually using the anti-double-stranded DNA antibody test, in which it is more specific than ANA, and if present, it also suggests the lupus nephritis. Okay, and then we can use anti-Smith antibody, in which it is specific for the SLE, but because it only approximately 30% of the SLE patient have this antibody, so it limits its clinical use. And we can use antiphospholipid antibodies like lupus anticoagulant and also cardiolipin antibodies to look for the predisposition to the blood clotting. And then other tests that we can use for SLE is actually complement C3 and C4, in which low levels suggest active lupus. How? Because during the flares, in patient's body, there will be a lot of the immune complex, right? So to remove of this immune complex, they use this complement, because one of the function of the complement system is actually to remove the immune complex, right? So that's why it's become low in SLE. And then C-reactive protein. C-reactive protein in SLE, it is normal. If it is high, so it indicates infections. And erythrocyte sedimentation rate, it is high in SLE, but in infection, it is also high. Okay. Okay, for the and this is just a test for to monitor the progression of the disease for the patient, like full blood count and reticulocyte count, in which we need to see the progression of the disease. We can use this test, and then urinalysis to identify patient with the lupus nephritis, and blood urea nitrogen and creatinine to evaluate the renal function of the patient, and cardiac enzyme, if present, it indicates myositis. And also we can do ECG, radiology, echocardiogram, MRI brain, and other organ assessment like skin biopsy, kidney biopsy, and rheumatoid factors. Okay, for rheumatoid factors, all autoimmune disease can have this rheumatoid factor. So we need to use the, like for the rheumatoid arthritis, if we suspect patient has SLE or rheumatoid arthritis, we can use, if we want to know if the patient has rheumatoid arthritis, we can do test of ACPA test antibodies. Okay, and then the criteria of the diagnosis. Actually, at the early course of disease, SLE is difficult to be diagnosed because because it involves multi-organ system. So the differential diagnosis is broad, and it includes infections, it includes malignancies and other rheumatological conditions, and also the post-streptococcal glomerular nephritis. So we need a good physical examination and also history taking. Supported with the positive laboratory findings. Okay, so and that's why several criteria have been developed to assist in classification of the SLE, and I have put one of the criteria in my slide, in which American College Rheumatology, I think, is a criteria for diagnosis of SLE. American College Rheumatology. Okay, this criteria, it said that more than 4 out of 11 criteria, which simultaneously or serially over time present in patient, then we can classify this patient has SLE. Okay, as you can see in the table, we can the criteria is malar rash, discoid rash, photosensitivity, oral ulcer, arthritis, serositis, renal disorder, neurological disorder, hematologic disorder, immunologic disorder, and anti-nuclear antibody. Okay. For the management, okay, for management for SLE, it's actually, before we go to the management, we need to know the goals of the management in SLE. It is actually to prevent the disease flares, to prevent the organs damage, and to maintain the resistance, to reduce use of the corticosteroid. As we know, corticosteroid is associated with many side effects, and also reduce drug adverse effect and improve the quality of life. So generally, we can ask the patient to use sun protection and avoid any outdoor activities that can directly expose the patient to the sunlight, and also treat any infection and give adequate nutrition like give vitamin D and calcium to avoid osteoporosis, because of the use of the corticosteroid. Okay, the risk of the long-term use of corticosteroid can have osteoporosis, and then immunizations to avoid any infections. Okay, but we also have the specific pharmacotherapy for SLE, in which corticosteroids, prednisolone or methylprednisolone. The difference is because we give orally, and methylprednisolone we give intravenously, and it required by all children. And corticosteroid is actually the mainstay of pharmacotherapy for SLE, but tapering of the dose should occur once disease is controlled, because just like I said before, corticosteroid is associated with many side effects, so we need to taper the dose to the lowest as possible and with the least side effect. And then immunosuppressive like azathioprine, methotrexate, cyclosporine, we started early for better outcome, and it depends on the system involved and severity. Okay, we can choose the immunosuppressive agent. Which one we want to use is depend on the system involved and severity of the disease itself. And then biologic agents. Biologic agent is actually for the resistant cases, and biologic agents, most of them are under research, and only 2 of them I found for that currently used for SLE, rituximab and belimumab. And then hydroxychloroquine, it is actually anti-malarial drug, but it can use to help to reduce the flares, reduce the autoantibody production and cardioprotective, but it needs eye screen and hearing assessment because it is ototoxicity, and because of the hydroxychloroquine induced retinopathy, and then and it needs special caution in impaired renal function. And then others like NSAIDs. NSAIDs we can use actually to relieve the arthralgia, the myalgia, kidney, and then calcium and vitamin D for patients to avoid osteoporosis, just like I said before. And then the follow-up management. Follow-up management is actually to check for the disease activity. How we need to do a detailed assessment of multi-organ to look for any active disease, or to monitor the progress of the therapy, and also complications of the disease, and psychological issues like self-esteem of the patients, and also the patient's compliance with treatment. And the complications of SLE is first one is avascular bone necrosis. Avascular bone necrosis is actually secondary to the corticosteroid use and infections, and also myocardial infarction. Myocardial infarction is one of the complications, because like in SLE, some patients have lupus anticoagulant, and this lupus anticoagulant is the risk for the myocardial infarction, one of the risks for myocardial infarction. Okay, and the last one is the prognosis. SLE actually have improved significantly over the past several decades, and it actually depends on which organ involved or which system involved. And the worst prognosis seen in patients with the severe lupus nephritis and cerebritis because of the chronic wrist disability and the progression of the renal failure. But current therapy like transplantation, it makes most patients live well into adulthood. Okay, that's all. photo. Do you have any questions? Can you hear me?
Any question for your friends? No? SLE, all this treatment, you guys need to remember. Just remember that there are immunosuppressants and also there are steroids involved. Clinical features have to remember, okay? The 4 of 11 thing, I think they don't quite use it any longer, but it's a good way to memorize all the features because they go by, what's the 4 of 11 thing? Yeah, it's a good way to remember the features if you remember the picture. Even though they don't quite use the 4 of 11 criteria and this all, I think they go by immunologic and clinical feature diagnosis. But it's multi-system, can be anything, so please memorize all the clinical features, okay? This picture is the most important part of the slide, basically. No questions, then last one. Capek, last.
I feel human, Doctor.
Afiq, start lah.
Okay, wait for a while. Can you see my slide?
Yes.
Okay, I'll start. Okay, Bismillahirrahmanirrahim. Assalamualaikum and good afternoon to Dr. Chan and everyone. So my name is Muhammad Afil Adlan. Today I will talk about inoculation line purpura. So before I start, I would like to tell the history of the disease. So the disease is named after Edward Heinrich Hinoch, a German pediatrician, and his teacher Johann Lucas Schönlein during the 18th. Proceed with the table of contents. So I will start with introduction, epidemiology, etiology, pathophysiology, clinical features, investigation, differential diagnosis, complication, management, and prognosis. So we start with the introduction. It is known as anaphylactoid purpura. It's defined by small vessel vasculitis of the skin, joints, kidneys, and gastrointestinal tracts, and it is characterized by IgA deposition in the small vessels. Next, the epidemiology is most common vasculitis in childhood. For age range, usually is 3 to 10 years old and peak at 6 years old. It is twice as common in boys compared to girls, and is peak during winter. For etiology, it is unknown, but it's usually preceded by upper respiratory tract infection in more than half of the cases by group A streptococcus, and also have genetic predisposition. So we move to the pathophysiology. Just like I said before, it is usually preceded by the upper URTI. So it will expose to antigen, which stimulate the IgA production. So the increase in IgA production will increase the circulating IgA production in the blood, which cause deposition of IgA immune complex in vascular walls, which then activate the complement system and cause vascular inflammation and damage to the affected organ like skin, joint, gastrointestinal tract, and also kidney. So basically, the pathophysiology tell us about it's not tell us. It's explain about the type 3 hypersensitivity reaction. So for the clinical features, for the history, like I said, it's usually preceded by the URTI and also fever. So during the physical examination, the inoculation line purpura have classical tetrads, which present in the patient. The first tetrad is the rash in most of the patient. Is symmetrically distributed over the buttocks, extensor surfaces of the arms and legs, and also ankles. However, the trunk is usually spare. So the characteristic the characteristic of rash is initially urticarial, then maculopapular, and lastly palpable purpura, which the most prominent can be seen in the patient. The second one is the arthralgia.
About the rash is that it's non-blanching, okay? That means if you press on it, the color doesn't change, right? It's non-blanching.
Okay.
You know what non-blanching is, not?
Not sure.
Who knows what non-blanching is? Let's bully somebody. So, Siti Maria. Siti Maria,
Yes, doctor.
what's a non-blanching rash?
Non-blanching rash.
Yes, non-blanching. BLANC.
It is a
Right.
rash that when we press, the redness does not go away. Is
Yes.
that correct?
Yeah, that's correct. So usually what people do is people use something clear, right? Like a clear piece of those, you know, those stethoscope, those glass slides you use. You press onto it, but there shouldn't be any color change to the rash, right? So it's non-blanching palpable purpura. So that's the typical rash that's described in HSP. So usually back extensor surfaces, buttocks going up. Sometimes you get a few purpuras on the ears. So when you get it, it looks quite. I mean, when you see it, then you know it's HSP. Continue, Afiq.
Okay, thank you, doctor. So the second tetrad is the arthralgia or arthritis. So it's usually affect the large joints of lower limbs, particularly the knees and ankles, and occasionally the upper limbs. So it's usually associated with periarticular edema with no significant effusion or warmth. Proceed with the third tetrad, which can the disease can involve in GIT involvement, and the patient may present with colicky, abdominal pain, and if gastrointestinal petechiae develops, it can present with hematemesis and melena, and also associated with nausea or vomiting. And lastly, the renal involvement, the patient the disease can cause glomerulonephritis, which present with hematuria microscopy or microscopically, and also mild proteinemia. And other signs, the patient may have subcutaneous edema and also scrotal edema. So for the investigation, the full blood count, the patient may have mild anemia, normocytic anemia, and elevated in white blood cell leukocytosis, and normal platelet count, which is important. Usually it is in the normal range, but may be slightly elevated. But why normal platelet count is important is to rule out the immune thrombocytopenic purpura, the ITP, which may have the low platelet count. So for the coagulation profile, you have normal proton time, activated partial thromboplastic time, and also fibrin degradation products. So this also to rule out the TTP, the thrombotic thrombocytopenic purpura. Next, the urinalysis. The patient may have hematuria or proteinuria due to the glomerulonephritis. ESR and C-reactive protein may be elevated due to the inflammation in the vascula. For renal profile, you have increased blood urea nitrogen band and creatinine levels due to impaired kidney function. IgA levels obviously elevated. And lastly, the abdominal ultrasound just to check the complication, which is the intussusception. So for the at least some of the differential diagnoses, the first one is immune thrombocytopenia, ITP, thrombotic thrombocytopenia purpura, which can which I said before, we can rule out in yes,
Immune thrombocytopenic purpura, isn't it?
immune thrombotic. Yeah. Yeah. I'm sorry. Immune thrombotic thrombocytopenic purpura. So we can exclude both of these in the investigation, check for the platelet count and also the coagulation profile. For the hemolytic uremic syndrome, we can exclude it if because hemolytic uremic syndrome will present with non-palpable purpura and also systemic lupus erythematosus and IgA nephropathy. Furthermore, for the complication, the most common complication present is intussusception. So intussusception is a condition which segment of the intestine invaginates into the adjoining intestinal lumen. For example, at the picture shown, the small intestine is invaginate in the large intestine, which can lead to bowel obstruction. And then we have ileus, is a lack of movement of the intestine, which can lead to blockage. Then we have protein losing enteropathy, nephrotic or nephritis syndrome. Orchitis is a inflammation of testicles and also hypertension. Other than that, for the management, usually most of patients recover quickly without treatment, but in several weeks. But in clinical, usually we used to have supportive therapy for rash, malaise, and fever by doing strict monitoring, analgesia, and maintain good hydration. In patient with arthritis, we can give NSAIDs to reduce the inflammation and pain, but need to be caution in renal insufficient patient because prolonged NSAID can cause nephropathy. And then systemic corticosteroid in patient to relieve the abdominal pain, subcutaneous edema, and nephritis. Usually we give prednisolone 1 mg per kg per day for 2 weeks. And lastly, immunosuppressive therapy for acute nephritis. For example, we give azathioprine, cyclosporine, and many immunosuppressant drugs and other immunosuppressant drugs. And lastly, for the prognosis, henoch-Schönlein purpura is generally a benign disease, which have an excellent prognosis. More than 80% of patients may have a single isolated episode lasting for a few weeks, and 10 to 20% of patients may have recurrences, but fewer than 5% of patients develop chronic henoch-Schönlein purpura, and the abdominal pain resolves spontaneously within the 72 hours in most of patients. So I think that's all from me. Thank you. Any question?
Fix start from the first slide again. I feel a lot of typos,
Oh,
the spelling, henoch-Schönlein purpura. Next. Next. I don't feel like. Okay, so basically it's a vasculitis, right? So all over the body, but vasculitis involving the whole body. Next. Okay, if you were in it peaks during winter because of the incidences of common cold. Incidences of common cold are a little bit higher right before winter. Next.
Yeah.
Next. Okay, so remember how it looks like? So that's how it looks like usually. Extensor surfaces or the back of the backs of the legs and then up the buttocks. I said sometimes you see the ears. Also, you can get a little bit of edema here and there. So sometimes you can get like the swelling over the forehead. It's weird, lah, but it is what it is. Arthralgia, arthritis, fine. Next. The presentation can be GRT. Okay, next. Oh, okay. Now presentation, they can present a few ways. They can either present with a rash, or they can present with hematuria, or they can present with joint pain, right? So you also can get atypical presentation. You can also present with a stroke. That's an atypical one because basically it's a vasculitis and inflammation of the blood vessels. So blood vessels are everywhere, right? So if you get inflammation of the blood vessels in the brain, that's a stroke, isn't it? Right? You get inflammation of the blood vessels in the kidneys, then you get nephritis, right? You get inflammation of blood vessels in your mesenteric vessels or the blood vessels along your intestines. That's where you can get abdominal pain. That's where you can also get things, the complications just now. You can get interception because interception. Okay, next. Next. Yeah, because interception is when the intestines telescope onto itself. When you get inflammation of the vessels, right? It acts like a nidus for the intestine to push against itself, right? Because the intestine is basically a tube, right? Intestine is basically a tube. So in interception, basically it telescopes into itself. Now, if you have a vasculitic lesion here that acts as a nidus, that means it makes it easier for it to break into itself. So if you get interception and it gets missed, so that portion will become gangrenous. So an atypical presentation would be also an acute abdomen, right? So they can present in the surgical ward of an acute abdomen. Next. Nephritis, hypertension. Hypertension secondary to the nephritis, right? Next. Basically, treatment is supportive. You don't use steroids, and this is low dose steroids only if the child has abdominal pain. Even then, only about 50% of the abdominal pain will be resolved with the steroids. This is low dose. Otherwise, it's mainly supportive. If the child has an acute abdomen, obviously go for surgery. If the child has nephritis, you treat the nephritis, right? If the child has arthralgia, arthritis, then you give pain relief. Otherwise, within 2 weeks, the child should get better by itself. Usually, it's not recurrent, but recurrence do occur. But if it occurs, then the child needs to investigate to see whether it's an autoimmune disease instead, rather than purely HSP. Next. Okay. And we're done.
Doctor,
Yep.
I have a question regarding the interception. So if the patient have interception present with complication, so how the interception can be treated?
Interception is surgical.
Oh, so
Yeah.
just
Either you do first, usually they'll try a barium reduction. That's non-invasive. That's radio. They go to a interventional radiologist or a normal radiologist can. So they can do a barium reduction where it's a tube, right?
yes.
Right. A barium reduction, basically they introduce they introduce the liquid to force it to unfold, right? If it cannot unfold, then it's surgical. You have to open up and they have to manually pull it open. That is why I was saying sometimes it can present to the surgical ward for acute abdomen, right? Because you have the interception, one, it can be done with intestinal obstruction, get a distended abdomen. Two, if there's interception wasn't picked up earlier, then you get gangrenous, right? And then you get peritonitis, and then they present to a surgical ward with an acute abdomen, right? So interception, it's either barium reduction. You also get it. This one, kids, you later on when you read, you get it. Interception occurs in toddlers, isn't it? Right? Kids who are just starting reading, roughly about 8 months to 12 months old. So either barium reduction. If barium reduction doesn't work, and they'll go open it up. So surgical intervention.
Thank you.
Any questions? Next question, no question. Any questions? Oi, any questions or not? Oh yeah, I wanted to.
No, doctor.
Wait, just now was who? Ah, Sharifah. How do you count body surface area?
What, doctor?
How do you count body surface area? You need to count body surface area in order to prescribe your prednisolone, right? 60 milligram per meter square. What's the formula for body surface area?
Height times weight.
Height in what unit and weight in what unit?
Centimeter
Okay,
times weight in kilogram.
okay.
Divide by 33600.
Okay. So
And then
height,
we square root, I think.
the whole thing square root, isn't it?
The whole thing square root.
The whole thing square root. Right, square root of the whole thing, height in centimeter times weight in kilograms divided by 3,600. Okay. You guys must know how to calculate. At least know the formula. Any question? Then we finish off.
Sure, doctor.
Okay. Bye-bye.
Thank you, doctor.
Okay,
Thank
thank you, doctor.
Thank you,
so much,
doctor.
doctor.
Thank you, doctor.
Thank you,
Thank you, doctor.